Good afternoon, everyone. My name is Katie Vlietstra-Wannenberg. I'm so excited for you all to join us this afternoon for this fantastic webinar that we have planned for you. On behalf of Consumers for Quality Care, welcome. We are really excited today to talk about standardized plans and individual market health insurance and have you join us. We'll go ahead and transition to the next slide, if you wouldn't mind. I think it's my face. I will be today's moderator for the conversation. And again, super excited on behalf of Consumers for Quality Care for you to join us today. The next slide, I just want to take a moment to thank all of our wonderful partners who have been along for this journey with Consumers for Quality Care. As you can see, we have a very robust and diverse group of partners. For those of you who are joining us today for today's webinar, if you're interested in learning more about CQC, we'll provide our contact information at the end of today's presentation. I think for a few little housekeeping items, just wanted to let you all know that the session is being recorded. And that we are really hoping to make this interactive. There's a lot of information that our great partners are going to share with you as we get into the meat of this webinar today. So we would love for you to engage. Because of the size of the webinar, we have gone ahead and muted everyone. And so if you have questions, please utilize either the chat function or the Q&A function. After the presentation, I will come back on screen and work with our team to answer the questions that you might have. And just feel free to, like, as the presentation's going on, just add them to the chat or Q&A, and I will keep track of all the great questions that you are asking of our amazing partners. I think with that, I am just incredibly honored and thrilled to introduce Donna Christensen, a former member of the United States Representative, a physician, and board member to Consumers for Quality Care. She's such a fierce advocate when it comes to healthcare, and the work that she did as a member of Congress and continues to do outside is incredibly admirable. So Donna, why don't I turn over to you to welcome our guests?
Thank you, Katie, and good afternoon, everyone, and thank you for joining us for today's event with Consumers for Quality Care and researchers from the McCourt School of Public Policy at Georgetown University on standardized health plans. My name, as you've heard, is Donna Christensen. I'm a board member of Consumers for Quality Care, or CQC. We are a coalition of advocates working to ensure patients and their right to high-quality health care remain at the forefront of the healthcare debate. CQC seeks to provide a voice for consumers to tell their stories and demonstrate to policymakers the imperative that is quality care. We are here today to dive into new research into standardized plans in the individual market health insurance and key considerations for consumer advocates in the formation of these plans. I'd like to introduce our panelists today, the lead researchers and authors of the Advocate's Guide to Standardized Plans. Kevin Lucia is a research professor and project director at Georgetown University's Health Policy Institute. As part of a specialized research team, Mr. Lucia conducts extensive legal analysis on how states and the federal government regulate private health insurance with a focus on access, affordability, and adequacy of coverage. Joanne Volk is a research professor at the Georgetown University Center on Health Insurance Reforms. There she directs research, authors papers, and provides technical assistance on state and federal regulation and legislation governing private health insurance, including health insurance marketplaces under the Affordable Care Act. Justin Giovanelli is an associate research professor and project director at the Center on Health Insurance Reforms at Georgetown University. He studies private health insurance and the effects of the Affordable Care Act on insurance markets and consumers. Dania Palanca is an assistant research professor at Georgetown University's Center on Health Insurance Reforms. She analyzes state and federal health insurance market reforms with an emphasis on insurance benefit design, access to health care, and coverage for chronic health conditions. Joanne and Justin will kick us off with a walkthrough of the research findings that informs the Advocate's Guide, followed by insights from Dania, who has advocated on standardized health plans as a member of the Standing Advisory Board for DC HealthLink and chair of the Standard Plan Design Workgroup, which makes recommendations for standard benefit plan design in Washington, DC. This discussion will be followed by a brief Q&A session where all of the panelists, including Kevin, will take questions from you, our audience. And now I'd like to turn it over to Justin and Joanne.
Thank you so much, Donna, and thank you, Katie, and thank you to everyone at CQC. It's a pleasure for us to be able to join you today and to talk about standardized health plans. We've been looking forward to this, and we hope to have a nice conversation here throughout the next hour. So on the first slide here, just to give you an overview of what we've been looking at and what we're going to be talking with you about. So the goal here from our perspective is to really get into a conversation and explain our understanding of why states and certain state bodies have decided to pursue standardized health plans in the individual market, why they've done that and how they've gone about doing that. And as part of that conversation, we hope to really hope to flesh out the benefits that policymakers in these states have identified for why they're pursuing standardized health plans, for why they've made that an option or why they've required that in some cases. So what are they going for here for consumers? And what sort of challenges have cropped up over the years with respect to the implementation of this policy, the realization of those benefits that policymakers have identified. So as Donna indicated, we're going to walk through the landscape of what states have been up to and the federal government actually for that matter too, over the last decade or so, giving you an overview of what we've seen. Talk a bit about some of the challenges, trade-offs that have been a part of this implementation of this policy over those years. And so we're looking forward to talking with you about that and then having some questions from you all and a conversation about that. So on the next slide, please. Thank you. So what are we talking about when we're talking about health plan standardization? So what we're really going to focus on here in the bulk of our conversation is standardization and the cost sharing parameters of a health plan. But to set up some background here for you, under the Affordable Care Act, Obamacare passed in 2010, came online in most of its critical respects in 2014. There is some standardization required by federal law, some but not complete. And so examples of the standardization that we see in that federal law are standards around benefits. So these are the essential health benefits, of which many of you may be very familiar. 10 benefit categories that all plans in the individual health insurance market and the small group health insurance market serving small businesses must offer. So these are 10 categories of benefits. And so standardization in what's required of benefits for the first time. Although even here, there is actually some leeway, as you may know, leeway for the states to define exactly what specific services fall into these benefit categories, and in some cases, leeway for insurance companies over the sorts of offerings within these categories that they provide. So that's one type of standardization, semi-standardization that we have already in federal law. Another aspect which starts to then come onto the cost sharing component are these actuarial value tiers. So these are the platinum, the gold, the silver, the bronze metal plans that you might be familiar with that are available on the ACA marketplaces and off the marketplaces in the individual health insurance market. So these are, again, some rough standardization for about how generous a plan is going to be in terms of how much it will pay for the care that you utilize under the plan. There is here again, though, considerable variation both within plans and potentially across states. So some level of standardization, not full. Lastly, we also have standardization in the sense that we have maximum limits on certain other aspects of a plan design. And so in particular, a yearly maximum on the out-of-pocket spending that a consumer can be asked to put forward on these essential health benefits. So a limit on MOOP. So that's in federal law. That's a lot, and that's certainly a big difference from what it looked like in the individual health insurance market prior to the Affordable Care Act. But it's by no means full standardization. And what in particular we don't have, and then what we'll be talking about here, really the remainder of our conversation, is more specific standardization in the cost sharing design, the deductibles, the co-pays, the co-insurance that plans offer in the individual market. So next slide, please. And so why might policymakers want that level of standardization? We already have some standardization. Why would we want more? What is that going to bring to consumers, at least in theory? So there are really two big buckets of reasons for why states have pursued this. Policymakers have thought long and hard about it, and why consumer advocates, as we'll talk about more, have pushed for these sorts of designs. The first is an attempt to make the process of shopping for health insurance, understanding one's health insurance options, somewhat easier, somewhat more simple. If any of you have been in a position to shop for coverage on your own rather than through your employer, but buy it in the individual health insurance market, well, going back prior to the ACA, it was often described as a bit of a Wild West in terms of trying to secure coverage in the unreformed market pre-ACA, where there was wide latitude for insurance companies in terms of what they might offer or what they might not offer to individuals. In particular, consumers who had prior health conditions, pre-existing conditions. So in the ACA world, as we discussed already, as I mentioned, there's considerable more consumer protections and more standardization, but it would certainly not be described as a simple, or should not be described as a simple and easy process to buy insurance. It's certainly always been a goal, but never been realized. It's complicated still to find the right plan for yourself. And so one aspect of standard plans is to try to make that decision-making process a little bit easier on consumer. If you put standardization in around the benefit design and make things roughly the same on these parameters, that allows consumers to take that one of many variables still and pull that variable out, and then allow consumers to focus more on other aspects of a plan. So you comparison shop on premium, on the provider networks that these plans make available, and in theory on the quality of the care that these plans connect you with. So that's one area of one key goal here. And there are various ways that you can potentially implement that goal, and we'll talk about that a little bit later. So the other main area, the other potential benefit that the policymakers identify when they're talking about standardized plans is an effort to improve how plans after purchase, after enrollment, how plans work for the people who enroll in them, to try to improve the value and the peace of mind that these plans provide the people who have them. There's been, and rightfully so, a long-standing conversation here about the affordability of health insurance coverage. Of course, not just in the individual market, but employer coverage as well. And a lot of times what we talk about is affordability in terms of the premiums for a plan. And as many of you may know, in the bill that is expected to be signed tomorrow, among the many aspects of that plan is considerable premium assistance for individuals who buy coverage on the individual market. But of course, another aspect of affordability is cost sharing affordability. How much a plan actually is going to cost you once you have it and once you try to use it. And there are various policy interventions for this, but standard plans potentially fits in very nicely as a way to address cost sharing affordability. And that's because policymakers can, at least in theory, develop a plan that promotes and higher quality care and types of care that consumers are most likely to need to utilize. And so you can come up with a plan design that puts primary care, for instance, prior to the deductible, so that even if one is faced with a large deductible, as many of us are these days, certain higher value types of care are available to a consumer before that deductible would otherwise apply. And so there are, while I think when standard plans were really developed in the various states that now have them, going back nearly 10 years, policymakers were thinking maybe in particular of the first area of simplifying plan choice. I think a lot more attention in recent years has really gone onto this second component here about the promise of higher value care through some standardization here. Next slide, please. So what are states up to these days? What kind of what states have standard plans? What are generally some of the rules around those plans? If we look on the next slide, we can see a map of the states that have standard plan requirements in their individual markets. So of course, probably the first takeaway, the first thing you see when you look at this map is that most states do not have these requirements, right? So the vast majority of states do not have standard plan requirements. It's really been thus far a function of less than 10 states who also, not coincidentally, operate their own ACA marketplaces. So the covered Californias, the New York State of Health, the marketplaces on which people buy subsidized coverage. And so you see the plans here, the states here that have had some sort of standardization, and most of these states have had standard plan rules from nearly the beginning of the ACA. Next slide, please. And so at a broad level, what are some of the policy decisions that these states have made? So 7 states and DC have these rules in place right now. Maine, as you saw from the last page, is highlighted on our map. They're going to be the 8th state, 9th jurisdiction next year with standard plans. The vast majority of these states, though, in DC, all but one, require some standardization, but not all standardization. So insurance companies that participate on these marketplaces must offer some plans that meet these standard requirements, but they don't have to have all of their plans meet those requirements. Only California requires complete standardization for all health insurance plans offered through their marketplace. Talk a bit more about why a state might or might not want to go that route in a few minutes. So what type of plans are standardized? This is another question that policy decide. Invariably, we're going to see that plans at the silver and gold metal tier, those actuarial value levels, also the bronze level tier, that those plans are going to be standardized, and there will be a standard form for those plans. Less frequently, but sometimes, we will see other standardization for other types of plans. Platinum plan, which are generally less common on the marketplaces. Other plans that are high deductible health plans may have standard form. So a couple other things to highlight for you before I pass the baton. So some other decisions to think about and that states have thought about is if you're committed to this notion of simplifying plan choice, do you take other related policy steps to make things easier for consumers to discern their choices, to see what's available to them? And so ways you might do that would be to limit the number of options that insurers have that are not standard. And we see some states doing that. Another way might be to require some standardization in the naming conventions for these plans, so that hopefully consumers can easily identify that a plan they're looking at is in fact standard. So on the next slide, I'll show you quickly here some of the basic characteristics of what a standard plan actually looks like, what some of these parameters are that are standardized across the states. And so, you know, on the left-hand side, you see data on the deductible for these various plans and silver level plans in these states. On the right hand, you see how these states have treated copays and coinsurance. You know, 2 quick takeaways I would put out there for you. The first is that you'll see some real similarities across states in terms of where these numbers line up. But they're not uniform across states. States have flexibility to find the right numbers for them, or at least to think through how that would work. And the second is, as you can see, these services in green on the right-hand side, many of them, or those services are ones that are pre-deductible. And so certainly it's been an attempt by the states here to put many of these higher value services and common services that people need prior to the deductible. So thank you so much as I run through that background, and I'm going to hand it over to my colleague Joanne to talk a bit more about how you might all think about these issues. Thank you so much.
Thanks, Justin, and good afternoon, everyone. My name is Joanne Volk. I'm going to talk through what this may all mean for advocates that choose to join the table in these discussions going on now in states and potentially in more states in the years to come as more states are considering them. Next slide, please. So if there's any one takeaway from my part of this presentation, it's that you will be faced with many trade-offs if you decide to engage in this process. On multiple factors. I mean, designing health benefits, I'm sure you know, requires multiple policy decisions and choices about where you apply the cost sharing and who benefits and who's going to be subjected to higher cost sharing. Of course, at the sort of threshold level is whether or not you prioritize lower premiums or lower cost sharing. Generally, the lower the cost sharing you have within a plan, the higher the premium. That's certainly the case with the premiums for the metal levels. But within the metal level too, if you're designing a standardized plan, if it's one that has lower cost sharing, it may be the plan with the higher premium. And one that prioritizes the premium may come at the expense of more cost sharing to get that lower premium. I will say that, as Justin mentioned, the American Rescue Plan to be signed tomorrow with the enhanced subsidies really makes this trade-off a lot easier and maybe even moot. And a lot of times people worried about the premiums for the unsubsidized population buying coverage in the individual market. Now everyone's going to benefit from subsidies to some degree with the new plan, at least for the next couple of years. So this particular trade-off gets easier in the years to come. But regardless, you're going to also have to consider trade-offs between how many services are provided pre-deductible and the cost sharing that applies once you've met the deductible, whether it's the co-pays or co-insurance or where you set the maximum out-of-pocket limit. You might have noticed in that colorful chart that Justin shared, Oregon has all of those services across the columns were available pre-deductible, but that meant then if you compared their cost sharing for their tier 3 and tier 4 drugs, that was 50% co-insurance, higher than other states' co-insurance for those tiers, or some had co-pays. So if you decide to put more services pre-deductible, you're going to have to make up for it on the other end, either with higher cost sharing or a higher out-of-pocket limit. And then the other trade-off we heard about a lot was the trade-off between, or the choices between co-pays and co-insurance. Co-pays, of course, are much more friendly for consumers. They're easier to understand. They can see exactly what their cost is going to be. They can't know what 20% co-insurance on a service is without knowing the underlying cost. They just can't. I mean, it's hard to do the math, even if you do have the underlying cost. But absent that, you have no idea what you're going to pay out of pocket. So co-pays are much easier for consumers to get their arms around. On the other hand, co-insurance, it may mean higher costs for consumers, but it also makes it easier for the people charged with designing these plans to deal with year-to-year changes that may be needed for medical inflation. So the same plan that worked this year may not work next year when you start to adjust for medical inflation. Using co-insurance will automatically adjust and you won't have to make these changes as frequently. On the other hand, it may be worth the effort to continually revisit and make those adjustments in order to get the co-pays and the fixed dollar amount required of patients so they understand their costs in a clear way. Next slide. Then there's also trade-offs and considerations. Some designs will be better for those with lower costs or less frequent healthcare needs. Others may benefit those who have regular, chronic conditions that require regular care or acute care that costs with, substantial costs. So if you want to prioritize lower cost sharing for the most enrollees, you may have to require higher costs for certain services that high cost conditions may require. The other feature is value-based insurance design. We didn't hear a lot of this. I think a lot of states were starting to think about it, perhaps because the last notice of benefit and payment parameters teed this up as a potential thing for states to pursue. And of course, VBIDs have been out there for a while. But if you were to pursue a value-based insurance design that targets a particular chronic disease, of course, or a set of diseases or conditions, I should say, it's, whoever's not on that list and all other enrollees do not get the benefit of that. So it may require higher cost sharing for those that are not targeted by the particular VBID design. And then within prescription drugs, there's some considerations. Some states have chosen to offer a separate lower prescription drug deductible than the medical deductible, or separate deductibles that are comparable to make it easier to access prescription drugs with your coverage. Some have decided to cover specific drugs like the lowest cost sharing tier or all generics pre-deductible. So there's decisions even within the prescription drug coverage of a health plan. Next slide. Now, moving on to actual challenges here beyond the trade-offs, the actuarial value itself. The plans must annually take into account annual updates to the federal calculator, how you actually, input some data as a plan to spit out your AV at the other end to learn how much is actually covered under the plan, as well as the out-of-pocket limit. I'm sure you all know gets adjusted every year according to a formula. That number keeps going up. So even the best laid plans and thoughtful policy discussions and designing a specific standardized plan design may be, dropped at the door when the NBPP comes out and the federal calculator is updated, and you quickly run your numbers again and find that you have to make tweaks just to fit within the target actuarial value tiers. We're all waiting for the annual update to the out-of-pocket limit right now. So this is, just this piece alone, getting this information late in the design process can really throw a wrench into the policy discussions and goals. The other thing we heard from actuaries is actually the federal calculator itself could be improved to at least make the actuarial values more reliable and consistent, and make it more likely that consumers are comparing apples to apples when they're looking at health plan A's silver standardized plan and compared to health plan B's. And that's because the calculator itself uses broad categories of services, much broader than the way the health plans actually think about how to categorize services. So they have some discretion when they're sort of putting in their numbers before running the calculation. And depending on how the insurers think about those inputs, you might get different results from the AV. So they all might come out with, for example, a 72% AV, but in fact, there's differences within those AVs that the consumers can't really see. And then the other thing is that the calculator is based on a national population, which can be very different from a state's particular population and healthcare needs. So an AV determined based on a national population may be, different than one for a particular state. And then also a lack of data. We were surprised at how little data really is being used here, certainly in a formal way. You might choose to prioritize so-called high value services pre-deductible. But when we really drill down to it, what is high value? Is it the services that the most people use? Is it the low cost services? Is it the services that are most closely correlated with better health outcomes? We actually found that there was very little data on those that the marketplaces were incorporating on a regular basis. Some states do have all payer claims databases or something akin to those that allows them to get some data. There's a lag in those claims, so it's not always real-time data on which you could make decisions. In other cases, we heard from some advocates that they would just sort of ask the insurers at the table, what are you seeing about utilization of these 3 free primary care visits before the deductible, to even just have those informal discussions and think about which services and which enrollees were using them to help inform what you prioritize in terms of cost sharing and pre-deductible coverage. Next slide. Some other considerations. Some states limit the overall number of plans any issuer can offer, whether standardized or non-standardized, or they might just limit the number of non-standardized plans. Generally for consumers, the fewer the choices, the better. There's been some research that the more choices there are, the less likely it is that a consumer will land in the best plan for them. I think a lot of marketplaces were reluctant to do that, at least in the early years. They didn't want to make it too cumbersome or unattractive for issuers to participate in the marketplaces. They wanted to have more plans to give consumers choices and help with competition. I think we've matured now to a place where that should not be as primary a concern as it was in the early years, and advocates can really push for a different conversation around what is the optimal number of plans, whether standardized or not, for consumers to really have meaningful and clear choices. And then finally, Justin touched on this a little bit too, the early experience with the states that were sort of the first out of the gate with standardized plans was they had done all this work to design these plans. And when our colleagues did some research on actually how they were displayed for consumers, frankly, all that work for designing the plans was sort of lost when consumers couldn't find them. They didn't know what it meant to have a standardized plan. They didn't know what to expect from them. They couldn't find them in the plan sort. So certainly states have decided to tackle this and are doing better in that regard, but that in and of itself is a task that you should keep in mind, that designing all the work to design what you think is the optimal plan choices will be lost if consumers don't have an easy way to find them and drill down and compare on them when they're shopping for coverage. So this does come at an opportune time, this discussion, I think, because certainly with the new administration, we might be able to revisit the policy that eliminated the federal version of standardized plans. At the time, it was only, of course, a choice for issuers. If they chose to offer a standardized plan, they could do so. We think there'll be an opportunity to ask that they, at the very least, it should be a requirement that they offer standardized plans. You could make that case now. I think there's an opportunity to do so with the next notice of benefit and payment parameters to require all issuers to offer a standardized plan. And then we know that several states are considering standardized plans. It is a low cost way, no cost way, other than the legwork and the data and the actuaries to really improve benefits for consumers, to make it easier to compare plans and prioritize certain services at a time when states may be really facing some fiscal constraints and limits on what they can do. This is one thing that you can do without having to cough up some money to do it. So we think several states will be considering this in the near future. So specifically how advocates can be prepared to engage in these discussions. Certainly have your clear goals at the outset. It can be overwhelming. You want to start to think about how, if there are particular types of consumers you want to prioritize. Again, the most benefit for the most enrollees or particular conditions, or like the people that have the highest costs over the course of the year shouldn't have a really high out of pocket. They should hit that sooner and get the benefit of their coverage sooner. Have your clear goals available, as you enter this discussion, but you need to be ready to adjust as you learn more. A lot of times we heard the consumers would have these thoughtful policy goals. They would convince the other partners and the stakeholder groups to come on board and pursue a policy. And then you get the actuarial value and you see it falls outside the actuarial value boundaries, and you have to start making adjustments. And then it might just become a matter of making the math work. The other thing is to be prepared to talk about the trade-offs. I've listed quite a few here, but you need to be really conscious about what those trade-offs are. They're, easier to do at the gold level because it's higher AV and there's just more more coverage to work with. But when you get to the bronze and silver, it's really tight and you may have very little room to make some choices, and they'll be made for you. The other recommendation is to really engage with an actuarial analysis. A lot of state-based marketplaces have their own in-house actuary, or they contract with actuaries to help them understand the implications of the various plan designs. We heard from some folks that as advocates at the table would develop relationships with the actuarial the actuarial firm, and ask them to weigh in with what different design choices might mean before locking into some design plans. We heard that the actuary can actually be a neutral party, where a consumer advocate might say, we wish to do X, Y, and Z because we think it's better for consumers. If you meet a wall of issuers or say, we can't do that, it's going to cost too much, the actuary can actually be a neutral party to help you understand what the quantifiable impact of those plan decisions would be. And then finally, it's really important to embrace a transparent process. Bringing in as many stakeholders as possible we heard can be really important especially when you're trying to map out a new policy goal. You don't want to have gone through all the work to, get some agreement on those policy goals, design the plans that meet those policy goals, and then have a late arriving objection from some other stakeholder that wasn't involved in the process at all. So we heard that can be a really important part of your advocacy here, is to insist on a transparent process. We actually also heard from some advocates who had been doing this for years and developed a real expertise and some relationships with various stakeholders, the insurers and the actuaries and the marketplace itself. And that can really prove beneficial when you're pursuing different policy goals. And now I'm going to turn it over to a long-serving advocate to talk about the real-world experience in the DC Health Benefit Exchange. Danya?
Hi, thank you. So I worked on this project as a researcher, but I am talking today as my role as a consumer advocate in the standardized plan process in Washington, DC. And within that, talking about how I've seen our findings and recommendations work in a real situation. So just a little bit of a history. I was initially involved in a work group before 2010 that recommended to the exchange that they create standardized plans. And I was initially vice chair of the standardized plan work group when it started in 2013. And I was working directly for an advocacy organization then, representing them. But I then sort of switched to Georgetown, and I'm now really an individual advocate on the work group and have become the chair of the work group. And I want to talk about 5 key points that have really worked through and been important in Washington, DC. The first is how consumer advocates work together and come to the table prepared. The other is how we've used our actuarial value expertise and really the benefit of actually having somebody who knows the calculator. Then I want to talk about the trade-offs and how we sort of decided some of those trade-offs. Then the struggles with the bronze plans, and it's truly a struggle anytime we try to design the bronze plans because they have such a low actuarial value. And then looking forward a little bit, the exchange is starting to look at how they can use standardized plans with an eye to equity. So first, being prepared. There have usually been about 3 consumer advocates that have been on the work group. There are also the insurers. There's just 2 insurers that are in the individual market. The ones that were in the small group market dropped out of the work group. We don't standardize their plans. And there's some providers, and those have included some community health centers that are generally aligned with the consumer advocates. But the advocates ourselves had regular phone calls outside of the work group meetings that we used to strategize, to talk about what our priorities are, and to discuss plan design options. Now, we had a lot more of these meetings in the first few years of standardized plans than we have now. And that's really because we were starting from scratch. In the second year, although we weren't starting from scratch, we really wanted to go back and look and say, are there things we really weren't happy about? And there was a lot more that we really needed to decide, because in the more recent years, we're really updating and sometimes changing something substantial, but we don't have the decisions across the board to make for the first time. And particularly in those first days, but also continuing, is that one piece we talk about a lot was that we wanted a goal to reduce costs to first dollar coverage, really to make it so that people can go to the doctor and people can get their prescription drugs. We didn't want that to be the only priority. There were concerns about people with chronic conditions, as well as those who have acute, expensive care needs. But we did really come with a primary desire to have that first dollar coverage. So I'd also like to walk through recommendations made by the insurers and options provided by the actuaries to make sure we were on the same page. So sometimes an insurer would come in and say, we think this should be the emergency room copay. And we might react in that moment, but it was also helpful outside the meeting for those of us who are consumer advocates to talk that through and see how important it was if we were not happy to push back on that aspect. And being on the same page is really one of the most important things that came out of our meetings. This way we could disagree when it was just us, but provide a united front in the work group meetings. It also meant we weren't all throwing out different ideas during the work group. So the work group itself was more efficient. And we were able to offer support of the proposals that another consumer advocate made. So if I were to make a proposal, I know I had the buy-in from the other two, so they would chime in, oh, I agree with Danya on this issue, which is really helpful to have that teed up because now you have 3 of the members of the work group who are supporting an issue. The next piece is the actuarial value expertise. This really is one of the most important pieces for when you come to the table. And I know it's an area that for many people and many groups will take a certain level of education, but I will admit it is not as difficult as it might seem. I know it can sound very daunting. You don't have to become an actuary. You just need to know some of the concepts. The reality is because we were in DC, all of the consumer advocates are currently or previously worked on ACA implementation with a national organization, which means we actually did come to the table with a good understanding of the actuarial value. So that helped us from the beginning. The actuaries that work as part of the work group, the DC Exchange hires, and they work for the exchange. They don't teach us or explain actuarial concepts to us. They will do a determination of the actuarial value of proposals we have if the work group comes to the desire to actually have those worked out, but we can't get up on the phone and say, hey, can you cost out changing the deductible to $4,000 and increasing the copays for doctors. It has to go through the exchange and through the work group. But what they're really doing is figuring out what the actuarial value is for different plans. And at the beginning of the process, they actually do come up with some recommendations of ways to tweak the plans to fit into the actuarial value to adjust for medical inflation. So being knowledgeable about the actuarial value has really helped us as consumer advocates to bring recommended changes to the table, in part because we have a sense beforehand of what those trade-offs might be and how big they might be. There are always times where you can be surprised because we may not realize how utilized a certain service is and what big an impact. And sometimes we get surprised with how little the impact is. But we're coming with a basic knowledge. And we're then also in the meetings really talking to the insurers as peers on the work group and not having to always rely on the insurance companies to come in and talk about actuarial value. And that means the insurers don't drive the conversation. And we were very lucky in the first years of the work group that one of the consumer advocates made herself very familiar with the actuarial value calculator. And this was really, really helpful because as we were building plans from scratch, she would put those plans into the calculator. And while we knew it may not have been exactly what the actuaries will determine, it gave us a sense of where we were falling and whether or not we were falling within the needed value for those medical tiers. And then even the years later, when we would make a tweak, it could help us to really know, is this going to increase the actuarial value significantly? Or is something small enough that we can bring to the table without a big trade-off? And it's been a loss having her. As I worked on this project, it actually made me realize that I should probably make myself familiar with the calculator to be ready to use it for next year. Although I am a little bit lucky because I'm the chair, which means I am in the early conversations between the actuary and the DC Health Exchange. They usually have some conversations before I come in, but I come in before the work group and can actually come up with some ideas that I want to see cost out and determined before that, which really helps. I also want to say that the calculator really shouldn't be as daunting as we are probably making it sound. It's not at all like filling out your taxes. It's really an Excel spreadsheet with sort of these calculations built in that you access online. And once you've become familiar and understand the data it's asking for, you really just plug in the cost sharing information. Where it gets complicated is when you get into real details about differences between certain cost sharing issues that are so much more detailed than what the standardized plans get into. If there were an issue where you were treating certain medical equipment different than other medical equipment, and we're just not getting into that much detail. So it's often relatively easy to do that, and really means that you're not going to be in that meeting and find out that you've proposed something that's going to increase the value by 2 percentage points and you're not prepared with trade-offs. So that brings me to trade-offs. And this is the crux of the work. When you're when you're designing a standardized plan, you can't put everything in that you want because you have to hit a certain actuarial value. So absolutely any recommendation will have a trade-off unless it is a tiny, tiny tweak to something. So some of the trade-offs we had were really discussed on a high level versus in the beginning versus trying to compare two plans and figuring out which piece we actually like more. So some of that was prescription coverage versus medical coverage. That you have, although you can still have similarities between them, you do need to decide if you want to prioritize something or you want to have them close to the same. The DC Exchange working group, and I would say the consumer advocates too, sort of made a commitment to try and keep prescriptions lower. Not to the point where we're just having to raise the deductible, $2,000. But we had this decision that really prescription drugs often are utilized across a broad population. So people that are healthy often have some prescriptions over the year. People with chronic illnesses often depend on multiple prescriptions. So you're kind of broadly helping people, was at least the feeling we came to the table with. But we also had to decide between cost sharing and co-insurance. And for a lot of the outpatient services, we decided we wanted cost sharing because it was easy to understand. Now, keeping the prescriptions down meant we had another trade-off, particularly the out-of-pocket maximums got a lot higher than I would have liked. I really hate how high the out-of-pocket maximums are. Some of that is just the reality, again, of the actuarial values. Bronze, you can't help it. But there was a decision by the group to really try to make as much care more affordable and as much access, as I said, to that first dollar coverage. So getting in to see the doctor, getting in to have that prescription, and even being able to afford the imaging or the lab tests. And that really helps more people by keeping more people's costs low. But the trade-off is the people who use the most care are then going to face higher bills. And you're just going to have to, at a certain time, determine that. And that means really people with very expensive chronic conditions and the people who might have a very expensive acute incident, such as certain heart attacks, newborns in the NICU that are in the NICU for a long time. Those are some of the situations that you have to realize you're trading off. And it's a really big thing that comes up a lot that might not be on the radar. Now, in the last few years, the exchange itself made a priority to have services pre-deductible. So that was something the advocates didn't bring to the table, but was brought to the table by the staff, but the advocates have really worked on. It's something the exchange is really proud of, and I would say I'm very proud of it as well. But when you make things pre-deductible, it does mean that other cost sharing has to increase. We increased the out-of-pocket maximums. We had to increase some co-payments. So again, you're working through all of these trade-offs again. And in this case, one of the big trade-offs was the cost for specialist visits had to increase. I wish they were lower, but if they were after the deductible, they would be a lot worse. Another trade-off we've had to make, which was sort of more of a surprise issue, but I think an example of some of the services you might not think of are ER visits. They're now $300 in the gold plan and a $350 copay in the silver plan. And it floored me when insurers first recommended that. Well, I actually think the actuaries recommended it or put it out as an option to meet the actuarial value. But what I was surprised at is that the insurer said that's really typical now, not just in the exchange, but it's something they're seeing more in group plans. It happened to not be something I had experienced myself in plans, but it's becoming more common. And it was one of those things, again, to keep more services pre-deductible and to keep ER visits pre-deductible. I do want to say, and this is one of those things to just remember to not just trust everything the insurers say, is the insurers kept saying to me that it's not a big deal because these copays are waived when someone's admitted, so they're never applied in actual emergencies. The second part just isn't true. Many people have emergencies like asthma attacks that don't require admittance. So if you have one of those emergencies that's a true emergency, but you don't need to be admitted to the hospital, you are going to face that copay. And so that just is a reminder, when you're going through these pieces, to not take everything at its word said by other stakeholders. Now, I want to briefly talk about bronze plans. It's the worst part of standardized plan design. We all hate it working on it, every stakeholder. And the first few years were actually the worst because we really were still coming to terms with how high the cost sharing is. These are plans that have at a max a 65% actuarial value, which means at the maximum, they cover 65% of the, of the costs of a population. That's really, really low. And when starting out, they had to be a max of about 62%. And DC, because they have a healthcare one that's compatible with health sharing accounts, we have one close to 60% and close to 65%, but they are hard. The deductibles are so high that they are actually just a few $100s lower than the out-of-pocket maximums. We struggled, we pushed to find something, but there are these tiny tweaks that are actually between that deductible and that out-of-pocket maximum that really aren't going to have significant impacts on the vast majority of people because that deductible is so high. And while we were able to make a few services pre-deductible, it's very limited. And specialist visits are now $125, which means for many specialist visits, the patient is going to pay less than the actual copayment because of the cost of that service with the negotiated rate. Now, if they see a surgeon, or some other specialist that's charging $300-400, it will be lower. And I'll say it's actually been easier the last few years because we've just come to the terms that these are basically catastrophic plans, that there's no way around it. And so it's become an easier thing to make tweaks to because we know we're not going to be able to make any of us happy. And then I mentioned an eye to equity. Moving forward, the DC Exchange has become committed to improving equity. They have a work group outside of the standardized work group that's focusing broadly on equity and issues around the exchange. And there's a hope that the next round of standardized plan design, which will be for plans for 2023, because we've already had to go through the 2022 design plans, but that design will be made with equity in mind. Now, you ask me what that means. I don't know exactly because we just started talking about it a few months ago. But some of the things I know and expect we are going to look at is whether there's conditions that disproportionately affect Black residents and people of color, and then whether we can somehow target lower cost sharing for treatments and services for those conditions. It's a little bit like value-based insurance design in that sense, but instead of trying to just what VBID considers increasing value and encouraging high value services, it's making it so it's easier for people to access conditions that are showing some of the inequitable aspects of the plans, so that you don't have a situation where without the desire or the goal, you really have plans that are helping out higher income white residents of the city more because it just happened to be how the plan design happened without our knowledge. So that's going to be looked at more. I haven't actually heard of other exchanges actively doing this, but I've heard some with some interest. And this really does show some of the options to use towards standardized plans, and moving forward, they really can be something different and meet more goals. So we can move on to the next slide and onto the Q&A.
Great. Thanks, everyone, for participating and staying with us. I know that we're quickly approaching the 2 o'clock hour on the East Coast, and so I know folks are probably transitioning to their next meeting. But I did want to say that if there are any questions that you have, we will share contact information, and please reach out. The team is more than willing to take questions via email. But I did want to actually ask, we had a partner put into the Q&A 2 questions that I think were interesting, and hopefully we can tackle them before the end. One is, they noticed that many of the states highlighted the current standardized plans I noticed many of the states highlighted the current standardized plans. Have any of the southern states done a good job of standardizing their plans? That is the first question. And I don't know, team Justin, who you want to farm maybe that out to. And then the second question is, how does this advocacy change for standardized plans about the ACA under the predict to change about the ACA under the Biden administration? So those are the 2 questions. Justin, do you want to farm those out?
Well, I'm happy to take the first, and perhaps Joanne can take the second. So quickly on the first, so no southern state presently requires or has any sort of regulatory framework for standard plans. As we discussed at various points in time, the federal government had a policy for optional standard plan designs for a few years ago, and may go in that direction in the future. But right now, the states that have done so are pretty limited, and really just those that are colored in on that map. Thanks for your question.
And I guess importantly, you have to be a state-based marketplace if you want to do something. Otherwise, you have to rely on the federal rules for the healthcare.gov. So if those states do not have their own marketplace, this isn't even an option unless the feds decide to implement it on healthcare.gov. In terms of other improvements, I mean, I really do think the big one is the one that I mentioned earlier, which is the fact that they're enhancing subsidies for those that currently get them and making them available to those who don't. You know, for those above 400% of poverty right now, they don't get any subsidies. And I guess the bill has been signed, will be signed today now. Premiums are capped at 8.5% of household income for all enrollees, regardless of, you know, there's no cutoff anymore. So that's a big deal for this, for the marketplace, but also for this process that we've described, to not have to worry about the premiums. I think that does allow states and the feds to consider ways to improve cost sharing. And of course, anything that improves cost sharing and makes those plans richer also makes it easier for standardized plans. You just have more to work with and not hit the constraints that Danya talked about with the bronze plans, with the low AV and high deductibles. You know, if there is improvement made on cost sharing, then that too makes all these trade-offs easier.
Fantastic. Well, we are perfect. Joanne, that's perfect. We're at time. Such tremendous information shared. I want to thank everyone for their time, their questions. We have put contact information both for Consumers for Quality Care and the Georgetown team. So please do, feel free to reach out. We would love to take your questions. And with that, we just want to extend our heartfelt gratitude for being with us during this hour. Hope everyone continues to be safe and healthy. And with that, we'll conclude today's webinar. Thank you so much for joining us.